So, very good evening to all. Today we are doing another session of the Journal Club of IAP Thiruvananthapuram, and we have our Honorable Secretary Dr. Benno, IAP Thiruvananthapuram, with us. We will be soon joined by Dr. Ramankutty sir, Emeritus Professor, SCTIMST, and we have joint coordinator and the mentor, eminent teacher Dr. Padmanabhan sir with us, and both the PGs Dr. Amalraj and Gopika also. And Dr. Sharda Devi Madam has joined, and we are expecting more also. So before we starting the session, I would request Dr. Benno to say a few words. Over to Dr. Benno.
Thank you so much, Anju K Kanmani sir. And as we all know that Journal Club and our Tuesday series, both are our flagship program. And we are continuing it very meticulously under the guidance and leadership of Padmanabhan sir, Ramankutty sir, and our Journal Club coordinator, that is Anju K Kanmani. So this has been talked about by almost all the branches across Kerala, and with even the main leaders of various branches. Even they are in the opinion that IAP Thiruvananthapuram is doing a wonderful job. Sorry, I'll just mute everyone.
Sorry.
I'll just mute everyone. Yeah. So sorry for that. And everyone is in the opinion that the Journal Club presentation, the topics have been very meticulously selected, and very apt topics have been selected for all the postgraduates, practicing pediatricians, and for everyone it is actually very useful. And not only that, there are good number of views in our IAP Thiruvananthapuram YouTube channel post the presentation, and so it has been appreciated by everyone across all over Kerala. So happy to be a part of the Journal Club presentation, and thank you, Anju sir, for that to carrying it forward with such persistence. So without further delay, I would like to as sir said that we have a very interesting topic for today, that is pertussis in Mexico from 2000 to 2019, a real world study of incidence, vaccination coverage, and vaccine effectiveness. And two speakers from PRS Hospital, that is Dr. Amalraj and Dr. Gopika ji. They will be doing the presentations. So all the best for the presenters, and I hand over the mic to Dr. Anju K Kanmani for the proceedings.
Thank you, Dr. Benno, for the nice, kind words. And we'll right away go to the Journal Club proper. And today's topic, as Benno was telling, it is very interesting because this wholesale pertussis and acellular pertussis, the topic is it's a topic of interest for senior pediatricians, practicing pediatricians, and even postgraduates and all. And today we have Dr. Padmanabhan sir. I think it will be prudent enough to ask Padmanabhan sir to say a few words regarding the topic, article, and the presentation. Over to Dr. Padmanabhan sir.
See, first I must justify why I selected this topic, because wholesale versus SLR vaccine is you go to meetings every time, you will find the same speaker talking against and for it. And you will find as I present through it, even the IAP and the WHO is little confusing. Therefore, there's worth. And why we presented this topic in the national conference, IAP conference in Ernakulam, it was stated categorically after the Mexican study, that is today's journal's topic, it has been proved beyond doubt that AP vaccine are in no way inferior to wholesale vaccine. This is the reason for today's selection. Therefore, the question is, were they justified in making such a comment? That is the question here. Screen sharing. Am I able to use the pointer? I don't know.
Yes, sir. It is working.
Okay. And the next. See now some of the basic facts. The wholesale vaccine is used in Indian National Program of Immunization, found to be effective and acceptable to the population. Almost all developed countries have switched to AP vaccine because it's considered less reactogenic. AP vaccines are available. The SLR vaccine available in India in the domestic market, and most pediatricians. I think I can use the pointer now. AP vaccines are available in India in the domestic market, and most pediatricians prefer that in private practice, as they were the only vaccine available till recently in the hexavalent form. And now now a new AP hexavalent vaccine by the Serum Institute, WP hexavalent, is available. Therefore, all the pediatricians will have to choose. Therefore, when in the national conference, it is said that AP vaccines are as effective as WP vaccine, in a crowd of about 800 top pediatricians with some of the authors of the test book sitting in the front row, nobody objected to it, and nobody gave any comment, including myself, because I had not read the Mexican study. They said after the Mexican study, which is a real world study, you don't have to look any further. Now, if you look at what the IAP has to say, this is the IAP Guidebook on Immunization 2018, and then as per the Purple Book in 2022 also, the SLR vaccine, as far as its priming is concerned, is inferior and duration protection is shorter. That is given in the textbook. Both the books is given, the latest one also. And we all know that the minor adverse effects following but the vaccination, wholesale vaccine is slightly higher, but the AP vaccine doesn't produce much of fever or febrile seizure or minor side effects. But the major side effect, if at all is there, is very, very rare in both. Therefore, the major side effect, this is by the IAP immunization, IAP in 2022 also. Now, this is not just a statement, because this is the immunological basis of it is also well known, produced by the WHO position paper 2015, which is the latest on pertussis, and also by the position paper of Indian Academy of Pediatrics 2013. A baboon model of pertussis suggests faster waning of protection of the SLR vaccine, limited impact on infection and transmission. The model suggests that both T helper cell 1 and 17 memory responses are needed to produce sterilizing mucosal immunity. In baboons, the AP vaccine induced only T helper cell 2, but lower T helper cell 1. And therefore, the scientific basis of why they say that the SLR vaccine is long-acting, the effect doesn't last long, is very well given. Now, you must understand this is a prime significance, because if you have given SLR vaccine and the person at 20 or 25 becomes susceptible to pertussis, the pertussis starts spreading in the adolescents and adults. Then the newborn gets affected and the newborn mortality goes up, and this is what is happening in the West. Now, if you look at the Purple Book, it's the latest. In 142, I'm giving you the page number also. They categorically say the resurgence of pertussis in a number of countries were found to be complex and varied, but the shorter duration of protection and probable lower impact of AP vaccine on infection and transmission are likely to play critical roles. Many studies in industrialized world documented faster waning of AP vaccine and protection wane in 4 to 12 years. This is the IAP. I'm sorry to say this, but in the same book, they will give the contradictory. 141, this is the statement. 131, they make a statement. In both the previous book as well as this book, it's not an erratum. Understand that. The efficacy and duration of protection with diphtheria pertussis SLR vaccine against diphtheria or tetanus and pertussis similar to that afforded by wholesale vaccine. See, direct opposite, 4 pages ahead of it. Therefore, there's a confusion there. And it is not an error, because this is given in 2018 IAP guidebook, and this is repeated in the 2022 IAP guidebook. And I have written to them, and they gave no answers to me. Actually, I wrote a letter to Kashi directly about this. He didn't return. Now, why are the AP? See, what do the Westerners have to say about why they are continuing to give SLR vaccine? This is given in Pediatrics, with the American Academy of Pediatrics official journal 2019. Despite robust vaccination schedules and high vaccination rates, many countries, including United States, have seen large pertussis outbreaks since the replacement of the wholesale pertussis vaccine with SLR vaccine. And in California, experienced 2 large pertussis outbreak over 9,000 cases. Most pertussis cases occurred among age-appropriately vaccinated children, suggesting that suboptimal vaccine effectiveness played a major role in pertussis epidemics. Therefore, they themselves acknowledge it. And if you are not very convinced, that's 2019, 2021, a Canadian study. If you are keen to see the meta-analysis, There's a systemic review, vaccine effectiveness, duration of protection. Analysis evidence continue to suggest that any pertussis vaccine confers protection in the short term. In the short term, both are good, although this protection wanes rapidly for AP vaccine. This is again, Manintu is a meta-analysis. Now, in the public, in the IAP guidebook, as well as both the latest IAP also, in the public health perspective, the Advisory Committee on Vaccine Immunization unambiguously support the current policy of employing wholesale vaccine. But we are more concerned of private because we have no say in the choice, and definitely it is working in the public sector. But when it comes to private sector, the things become little dodgy. The Indian Academy, this 2018, has now issued the following recommendation of his practice. The primary infant series should ideally be completed with 3 doses of wholesale vaccine. They said it in 2018. I even give you the page number 149. But, as usual, in the same book in annexure, they said both wholesale vaccine and AP vaccine combination can be used in the primary series. I'm sorry to Benno, but I have to say this. Normally, they say the right hand doesn't know what the left hand does. But as far as IAP goes, the right hand doesn't know what the right hand does. That's the problem here. How can you write in the same book such contradictory statements? Now, when they said that categorically, here they have said categorically that wholesale vaccine should be used. In 2022, they came down a little. The primary series should be complete 3 doses of either wholesale or AP vaccine. Wholesale vaccine is definitely superior to AP vaccine in terms of efficacy and duration of protection, but more reactogenic. But remember, reactogenic is only for minor reaction. And our parents are happy with it. And not in view of the parental anxiety and concern, AP vaccine can also be administered in primary series. You see, if something is more efficacy and more effective, is it not our job to counsel the parents in that way rather than telling that we go by their fear? Anyway, that's not. Now, if I am not keeping on blaming the IAP, the WHO is also equally confused. The WHO position 2015 in pertussis, the latest on pertussis they have, it says can be obtained with primary series of either wholesale or AP. It can give either of them. Available evidence indicate there is more rapid waning of immunity and possibly reduced impact on transmission. Because it has herd immunity wholesale with AP relative to W. How can they then say you can give either of the vaccine? I don't understand. WHO further says, note these words, you have to read in between the lines. States that the national program currently using AP vaccine may continue. Okay, if you are using AP vaccine may in the Western, you may continue, but should consider the need of additional doses. And national program currently using wholesale vaccine should continue with the WP vaccine. If you read the national therefore, just because the Western countries are gone in for AP vaccine, for wholesale vaccine, they cannot revert back. WHO is not insisting on it. That's why you must read in between the lines. Now, the WHO further goes on to state a switch from wholesale to AP vaccine for primary immunization should only be considered if additional periodic boosters or maternal immunization can be assured. Therefore, in our country where this cannot be assured, giving it even in private practice, AP vaccine may not be very advisable. Now, this is written in where is it? Given in the New England Journal of Medicine, it can't get better than this in 2012. Now, evaluation of data of a large pertussis outbreak in California showed that protection from the disease after 5th dose of DTaP vaccine among children who had received only DTaP vaccine was relatively short-lived and waned substantially each year. Therefore, and they say this, they say that it lasts only for 5 years. That I didn't put it up here. Therefore, even when what happens in India is we give the booster, I mean, in 10th year, we are giving a TDAP, 16th also it is advised by the IAP, then it is not advised except for pregnancy. In Western countries, they are advising every 10 years. And this article even goes on to say that it lasts only for 5 years, even if you give a booster. Now, the question is, has this Mexican study put a lid on the controversy as some have claimed in the IAP meeting? Let's analyze this article for the answer. That's why I took up the share And I'm sure that this article will show light on this particular matter. Can I close it?
Yes, sir. Thank you very much, sir, for setting up the background for the analysis of this paper. And Dr. Ramankutty sir has joined. Welcome to the session, sir. Today we have Dr. Amalraj R and Dr. Gopika J, both enthusiastic postgraduates from PRS Hospital. Dr. Amal will be presenting and Dr. Gopika will be analyzing. Over to Dr. Amalraj for the presentation. Amalraj, you can start screen share. Thank you.
Good evening, all. Today my topic is real-world study of incidence and comparing between acellular and wholesale pertussis vaccine. It is published in the article 41 that is published in 2023. Coming to introduction. Over the past 20 years, there has been a sustained increase in the global prevalence of pertussis, and between 2008 and 2015, there is a surge in the pertussis cases with outbreaks declared in many countries, including Brazil and Mexico. In 2012, PCR testing became widely used for the accurate diagnosis of pertussis in Mexico, resulting in the spike in the number of cases. In Mexico, the wholesale pertussis vaccine is switched into acellular pertussis vaccine in the year 2007. This year is called the transition year. The method using Mexican National Database Health and Population Surveillance that is done in 2000 to 2015 assess the incidence of pertussis, infant pertussis vaccination coverage and vaccine effectiveness against clinically diagnosed and or laboratory confirmed pertussis. The age group is 6.5 to 18.5 months or 24.5 months for the primary series, and the children age 18.5 or 24.5 to 48.5 months for the total booster. In Mexico, the pentavalent vaccine containing wholesale pertussis vaccine introduced into 1999 and they switched into pentavalent vaccine containing acellular pertussis component in 2007. And 2019, they introduced hexavalent containing acellular pertussis vaccine component. The acellular pertussis vaccine used in the Mexico has two components, pertussis toxin and filamentous hemagglutinin, and is given to children as 3-dose primary series at the age of 2, 4, and 6. In response to 2012 resurgence in the pertussis, the maternal pertussis vaccination program were introduced into a number of countries, including Mexico, to provide protection against pertussis in infants during the first week of life before the age of routine pertussis vaccination. There are currently no data available about the effectiveness of two-component acellular pertussis vaccine used in the Mexico. The aim of this retrospective National Health Database study was to address the evidence gap and quantify for the first time the real-world effectiveness of the acellular pertussis vaccine used in the Mexico. Study design is mainly a retrospective observational study based on the national database done in Mexico and assess the coverage and effectiveness of 3-dose primary series.
Please mute.
I'll just mute everyone. Sorry. Dr. Amal, you can unmute yourself. Everybody's muted. You can unmute Amal.
I think Dr. Amal, you should unmute and talk.
Okay. Dr. Amal, okay.
Thanks.
If unmute, okay. Yeah, can continue.
The study design consists of retrospective observational study of National Database of Health and Population Surveillance in Mexico. The coverage based on the 3-dose primary series and 4-dose infant series mainly against clinically diagnosed and or confirmed with PCR testing in children between age 6 and 48 months. 3 national databases were used to obtain the data. The case reported the time limit is 1st January 2000 to 31st December 2019. The National Epidemiological Surveillance System, SINAVE, consolidate the information for all diagnoses reported by both the public and private healthcare sector. The SINAVE collate information on age, geographical state, year of vaccination and vaccination status by case and dose of vaccine received, as well as the type of vaccine, clinically only or confirmed with confirmation method like PCR. All diagnoses are listed by International Classification of Disease, that is ICD-10. Pertussis specific codes were used to identify clinically and laboratory confirmed cases within the database. Anonymous aggregated data was used. As such, of no formal approval was required from the ethical committee and informed consent was not required. Coming to vaccine, over the study period, the vaccine schedule in Mexico included 3 doses of pertussis vaccine for the children aged 2, 4, and 6, unlike in our country, and that is followed in 6, 10, and 14 weeks. A total booster dose was required at the 24 months of age during the wholesale pertussis vaccine period and 18 months of age during the acellular pertussis vaccine period. Pediatric pertussis vaccine used in the National Immunization Program has already been discussed. The transition year is 2007. In that year, the wholesale pertussis changed to acellular pertussis. Coming to case definition, during the study, the pertussis cases were those recorded in the SINAVE database with ICD-10 codes of A37 category. A clinically diagnosed case met the clinical case definition of the Mexican SINAVE but was not laboratory or epidemiologically confirmed. The Mexican SINAVE clinical definition is any cough more than or equal to 14 days with more than or equal to 2 days of paroxysmal cough. The confirmed case met the clinical case definition and was confirmed by one laboratory test or an epidemiological link to a confirmed case regardless of the laboratory method used, that is serology, PCR, or culture. The clinical definition may have varied during the study period considered, yet all relevant cases which met the SINAVE definition between 2000 and 2019 were included in the study. Coming to vaccination status, pertussis cases were categorized as fully or incompletely vaccinated based on the data retrieved from the official SINAVE database. The fully vaccinated definition is child having received all recommended doses for their age more than or equal to 2 weeks before the diagnosis of pertussis or at the start of pertussis symptom. Coming to statistics, incidence of pertussis and vaccine coverage annual case numbers and incidence rate were estimated for all notified cases and stratified for clinically diagnosed and laboratory confirmed. Incidence rates of pertussis infection were described by the age group for each year 2000 to 2019. The age group defined in relative to vaccination schedules such as age less than 6 months, 6 to 17 months, 18 to 47 months, and more than 48 months. The annual vaccination coverage rates for the 3-dose primary series and 3-dose primary series plus total booster dose were estimated by dividing the dose administered as recorded in the census by the age-specific cohort population size as determined from the CONAPO data. The vaccine effectiveness was calculated for 3 doses, that is case occurring between the age of 6.5 months to 18.5 or 24.5 months, and for 4 doses, case occurring between 18.5 or 24.5 months and 48.5 months. The proportion of the vaccinated cases, that is PCV, had received 3 vaccine doses and the children aged 18.5 or 24.5 to less than 48.5 months had received 4 vaccine doses was estimated annually and for the period specific cohort. Vaccine effectiveness was estimated using the screening method based on the proportion of the vaccinated cases and the proportion of the vaccinated individuals in the population. The analysis considered that proportion of the infants may have received only 1 or 2 doses. To estimate absolute vaccine effectiveness, the proportion of the vaccinated for 3 or 4 doses was estimated relative to the population who had received the first dose. The equation is given below, that is vaccine effectiveness equal to proportion of the vaccinated cases minus proportion of the vaccinated individuals divided by proportion of the vaccinated individual. And equation B denotes the same equation, that is PPV, the proportion of the vaccinated individual, DTPx equal to 1 if individuals who receive more than or equal to 1 doses of pertussis vaccine, and DTP1 if it is unvaccinated individuals. Sensitivity analysis were performed for each vaccination status, 3 dose and 4 doses, estimating vaccine effectiveness restricted to laboratory confirmed pertussis cases only. A logistic regression was performed with vaccination status of the cases as the dependent variable, annual counts as frequency weight, and logic for the annual vaccination rate as offset. These are the incidence of the pertussis that is shown in the bar diagram. Overall, there was a trend of increased incidence of pertussis notification over the period of 2000 to 2019 in all age groups, driven mostly by the cases in young children. By age group, in all year, the highest incidence of notified pertussis cases were observed among infants aged less than 6 months. This is the most important age because this is the vulnerable group, and maternal pertussis vaccination cannot protect this group also. The years with highest incidence overall is more than 1,000 notified cases were 2012, 15 and 2016. The vaccine effectiveness of the both vaccine. For 3 doses of pertussis vaccine compared with no vaccination, vaccine effectiveness against all notified pertussis for the wholesale pertussis vaccine was about 96.4%, and the acellular vaccine period, that is about 95.7%. In the sensitivity analysis restricted to laboratory confirmed cases, in that settings, the wholesale pertussis vaccine coverage was effectiveness was about 97.3%, and acellular pertussis vaccine was 97.2%. Coming to conclusion of the study, over the 19-year study period, 3 doses of pertussis vaccine in a real-world contemporary setting conferred very high protection against clinically diagnosed and or laboratory confirmed pertussis with comparable vaccine effectiveness of more than 95% for both wholesale and acellular pertussis vaccine. Our study showed that in real-world contemporary setting, that is conducted in 2008 to 2019, after 3 or 4 doses, the 2-component acellular pertussis vaccine was highly effective at protecting against pertussis at least until the age of school entry when assessed through the screening method. That is, the study is done up to the school entry age group. Thank you.
Thank you, Dr. Amal, for that excellent presentation. And you can stop sharing. And I would like to request Dr. Gopika to present the analysis, or Dr. Gopika.
Good evening, everyone. My topic of presentation is about the analysis of the study, Pertussis in Mexico from 2000 to 2019, a real-world incidence study of incidence, vaccination coverage,
Louder.
and vaccine effectiveness. The analysis is based on the STROP checklist. As per the STROP guideline checklist for cohort studies, there are 22 items that are analyzed in any particular study. First is the title and abstract. In the title and abstract, the STROP indicate the study design with a commonly used term in the title or abstract. And this study have a title which doesn't mention about the study design, but it says about the incidence, vaccination coverage, and vaccine effectiveness. And the study design is said in the abstract. And according to the STROP guidelines, the abstract should provide an informative and balanced summary of what was done and what was found. And the abstract of this study is divided into background, methods, results, and conclusion. And in methods, they are mentioning about the study design, that is a retrospective study design. The second category is introduction, and the second criteria in the checklist is background or rationale. And in this, the study should explain the scientific background and rationale for the investigation being reported. And the study says the National Immunization Program in Mexico includes a 3-dose primary series of pertussis vaccine and a toddler booster dose. And in Mexico, wholesale pertussis vaccine was switched in 2007 to a cellular pertussis vaccine. Currently, there is no data available about the effectiveness of the 2-component AP vaccine in Mexico. To evaluate the protection against pertussis infection achieved in the National Immunization Program and to estimate the real-world vaccine effectiveness of the 2-component AP vaccine. The third criteria is objective. According to STROP, the study should state the specific objective, including any pre-specified hypothesis. And this study have 2 objectives, that is primary objective and a secondary objective. The primary objective is to estimate the vaccine effectiveness of the 3-dose and the 4-dose vaccine series of the WP and AP pertussis vaccine against pertussis in children aged 6 to 48 months between 2000 and 2019. And it is estimated by the age group and separately for the WP vaccine in the period 2000 to 2007 and AP vaccine period in 2008 to 2019. The secondary objective of the study is to describe the age group specific incidence of the pertussis. And the next heading in STROP's checklist is methods. And the method should include the 4th criteria, that is the study design. And this should present key elements of the study design early in the paper. And this study is a retrospective observational study design. And the setting of the study, STROP says that they should describe the setting, location, and relevant dates in periods of recruitment, exposure, follow-up, and data collection. The location of the study is Mexico, and the relevant dates are 1st January 2000 and 31st December 2019. Data collection method is based on the national databases. The follow-up period is, since it is a retrospective study design, there's no follow-up, but the total study is taking place in age group 6 to 48 months. The participant is the next criteria. According to the STROPs, the study should give the eligibility criteria and the sources and methods of selection of participants and should describe the methods of follow-up. The eligibility is clinically diagnosed or lab confirmed pertussis in children age 6.5 to 18.5 or 24.5 months for the primary series and children age 18.5 or 24.5 to 48.5 months for the toddler booster. The resources for the study is from 3 national databases, that is CINAVE, CONAPO, and CINSIA, which was discussed later before. And the next criteria in the STROP's checklist is variables. The study should clearly define all outcomes, exposure, predictors, potential confounders, and effect modifiers, and if possible, to give a diagnostic criteria. This study have a diagnostic criteria which is based on Mexican CINAVE. And according to that, a clinical case is the one which the patient is having a cough for more than or equal to 14 days with more than or equal to 2 days of paroxysmal cough. And a confirmed case met the clinical case definition and was confirmed by one laboratory test or an epidemiological link to a confirmed case, regardless of the laboratory method used, which can be serology, PCR, or culture. And the confounders are discussed under limitations of the study. The next criteria is data sources. For each variable of interest, give sources of data and details of methods of assessment and describe the compatibility of the assessment methods if there is more than one group. Every variable was studied from the data from the national databases discussed before. The 8th criteria is bias. Describe any efforts to address the potential source of bias. This article does not mention any biases in the study, but in general, retrospective cohorts have an information bias, which is missing information regarding the notified case, and there is no efforts in the study to address the bias. The 10th criteria is study size. There is no specific sample size defined for the study. All data available are included, and the data was previously mentioned. The quantitative variables are the next criteria. STROP's analysis checklist says that the study should explain how quantitative variables were handled in the analysis, and if applicable, describe which groupings were chosen and why. The main quantitative variables are incidence, vaccine coverage, and vaccine effectiveness. The incidence is annual case numbers and incident rate were estimated for all notified cases and stratified for clinically diagnosed and lab confirmed cases in the mentioned age groups. And vaccine coverage, annual vaccine coverage rates for the 3-dose primary series and 4-dose series were estimated by dividing the doses administered as recorded in Censia by the age specific cohort population size as determined by the CONAPO data. And the third variable is vaccine effectiveness, calculated for 3-dose in cases between 6.5 months and 18.5 months, or 24.5 months and 48.5 months. And the formulas for these was discussed earlier. The 12th criteria is statistical methods. The study should describe all statistical methods, including those used for control for confounding, and describe any methods used to examine the subgroups and interaction. This study is using a chi-square test, that's a statistical method used, and the probable subgroups in the study are cases during epidemic and those in whom maternal vaccination was taken, and no subgroup were analyzed and examined in the study. And the STROP checklist also says that the study should explain how missing data were addressed, which was not addressed in the study, and if applicable, explain how loss to follow-up was addressed, which is also not applicable because this is a retrospective study, and describe any sensitivity analysis which is done in this study. The 13th criteria is results. The result should report number of individuals at each stage of study, example the numbers potentially eligible, examined for eligibility, confirmed eligible, included in the study and completing follow-up, and they should be analyzed. And give reasons for non-participation at each stage and consider use of a flow diagram. This study is using a bar diagram for the results. There are 2 bar diagrams, that is, one is for the number of notified pertussis cases by methods of diagnosis, where the number of notified cases of pertussis is mentioned in year-wise. And the second bar diagram is an incidence of clinically and or laboratory confirmed pertussis cases by age and in the total population, where the pertussis incidence rate is mentioned in the vertical axis. Descriptive data. Give characteristics of the study participants, example demographic, clinical and social, and information on exposures and potential confounders, which is not done in the study. Indicate the number of participants with missing data for each variable of interest, which is also not available. And summarize the follow-up time, example average and total amount. This study is not follow-upping the cases, but this is since it is a retrospective study, but the study is conducted up to the school age time. The vaccine coverage rate and the following details were discussed before. The outcome data, the report the number of outcome events or summary measures over the time. And the outcome data, the study is publishing the outcome data via 2 tables. One is wholesale and acellular pertussis vaccine effectiveness estimation for 3 doses versus no vaccination in children aged 6.5 to 18.5 months. And the second is a wholesale and acellular pertussis vaccine effectiveness estimation for 4 doses versus no vaccination in children aged 18.5 to 24.5 for wholesale pertussis vaccine. The main results. The STROP checklist says that the main results should give unadjusted estimates and, if applicable, confounder adjusted estimates and their precision, which is done in this study. And the study should make clear which confounders were adjusted for and why they were included, which is discussed below. And report category boundaries when continuous variables were categorized. And if relevant, consider translating estimates of relative risk into absolute risk for a meaningful time period. The potential confounders in this study are, first one is data was not determined based on individual level registries, and the number of eligible children was based on census data and projection, potentially leading to random errors that may reduce the accuracy of vaccine effectiveness estimates. The second potential confounder is geographical region may also have confounded these analysis with vaccine coverage differing between states or regions. And the third is confounding factors at the individual level, such as specific pertussis risk factors and significant difference between the vaccinated and unvaccinated groups also represent potential limitation. The confounders in the study were listed but were not analyzed in the study, and nothing could be done to address it. The reporting and analysis of other groups, that analysis of the subgroups and interaction and sensitivity analysis as discussed before. Key results. Summarize the key results with reference to the study objective. The study showed that the contemporary setting, after 3 or 4 doses, the 2-component AP vaccine was highly effective at protecting against pertussis at least until the age of school entry when assessed through the screening method. And the results were comparable to the other vaccine effectiveness data reported in similar age groups in other countries using similar methodologies. Any comparison between the WP and AP vaccine should be done cautiously due to the age group difference for the 4th dose between the different vaccine. And the incidence of the pertussis sharply increased in 2012 and was highest in 2012, 15 and 16. And the coverage was highest for the first dose in the primary series, decreasing for the subsequent doses. The conclusion of the study's findings suggested high levels of vaccine effectiveness overall were achieved for the AP and WP vaccine in Mexico between 2000 and 2019. The limitations. Discuss the limitation of the study taking into account sources of potential bias or imprecision, and discuss both direction and magnitude of any potential bias. The study is reliant on routinely collected data and are thus subject to the inherent key limitation of potential underreporting of cases. Furthermore, while the screening method has the benefit of a large population comparison, its ability to control for potential confounders is limited, and this method is particularly sensitive to very low vaccine coverage rate. Vaccine coverage rates were estimated based on the number of doses administered. However, this was not determined based on individual level registries, and the number of eligible children was based on census data and projection, potentially leading to random errors that may reduce the accuracy of vaccine effectiveness estimates. And geographical region may also confound this analysis, which was discussed before. And the study considered the potential impact of geographical region with additional sensitivity analysis. The interpretation of the results was impeded by the lack of statistical power. Confounding factors at the individual level can also be considered as a limitation. The limited capacity for laboratory confirmation in the early years of the study may also represent a limitation in the study. And maternal pertussis vaccine introduced in Mexico in 2014 may also have impacted the incidence of pertussis in Mexico during the study period. Interpretation of the results. According to the STOPS, the study should give a cautious overall interpretation of the results, considering objectives, limitations, multiplicity of analysis, results from similar studies, and other relevant evidence. The study showed that in real-world contemporary setting, after 3 or 4 doses, the 2-component AP vaccine was highly effective at protecting against pertussis at least until the age of the school entry when assessed through the screening method. Short-term effectiveness of AP vaccine was never in doubt. The consistency of the year-on-year vaccine effectiveness data in the study and their close comparability to data objective through the obtaining through the robust case control study lent support to our interpretation of the analysis. And despite the inherent design limitations of the screening studies, they are still frequently used to estimate vaccine effectiveness, not only for pertussis, but also other infectious diseases such as flu. And notably, the years of lowest pertussis vaccine effectiveness coincided with those with the lowest vaccine coverage, highlighting the importance of achieving the WHO target for more than 90% coverage of DT. The 21st criteria in STOPS checklist is generalizability. Discuss the generalizability or external validity of the study results. The results were comparable to other vaccine effectiveness data reported in similar age groups in other countries using similar methodologies. Finally, any comparison between WP and AP vaccine should be done cautiously due to the age group differences for the 4th dose between the different vaccines. The 22nd criteria in the STOPS checklist is funding. Give the sources of funding and the role of the funders for the present study, and if applicable for the original study on which the present article is based. This study is funded by Sanofi and they were involved in the study design, including the protocol development, data analysis plan, interpretation, and manuscript writing. Thank you.
Thank you very much, Dr. Gopika, for making us realize the issues concerned with this study, as well as the advantages, disadvantages, etc., and analysis it through the stroke guide. Now, we will go to the proper expert analysis by Dr. Ramankutty sir. So, I request Dr. Ramankutty sir to throw some light on the article, the way it is being done, and the clinical implications. Or to Dr. Ramankutty sir.
Thank you. Anyway, I'm very glad that this article is taken up because there are several issues. One is you can discuss this article purely as an academic exercise on how the article has been done, and I think it's been excellently presented and analyzed by the postgraduates, especially the analysis part has been done very well. So congratulations to both of you. And as has been pointed out, this is a retrospective study. This is a retrospective because they are looking at vaccination as an exposure and how it has been effective in preventing or limiting new cases of pertussis, and they're comparing the two vaccines also. And it is done from already present database. So there are several biases which are possible, like what has been captured, what has not been captured. And we assume that in this Mexican database, everything is captured. That is what they claim, and probably I don't know how good that is. I mean, we know how these things are done here. So anyway, so that is one important concern. But assuming that this data is reliable, then what they have said is that they have high, when you have high levels of coverage like 90% and above, there is not much to choose between these two. But then the question is this the right design to look at whether something is more effective than the other? Because as Dr. Padmanabhan presented, there are other designs possible, and they have done, somebody has done a systematic review and meta-analysis and shown that probably this is not the what results. So this is just one database which they have looked at, which is fine. Of course, I'm not saying this paper is bad, but and they have found that, I mean, what we can conclude probably is that at high levels of coverage, probably there is nothing much to choose, but maybe you have to tie it with also, as has been rightly pointed out, there are many confounders possible, especially the regional differences are probably one of the important confounders. Actually, what they have done is, I was wondering why they did not do a case control study till I realized that the individual, it was a anonymized data, so they didn't have individual who is the case, who is not the case, whether the case is vaccinated, they don't know. So they had to kind of split it up into age groups and look at what is the proportion vaccinated and then correlate it like that. So in that sense, more than a cohort study, it is what we call an ecological study. Ecological study means the variables are measured at the group level, not at the individual level. So in ecological studies, there is always this ecological fallacy that what is true at the group level may not be true at the individual level. So that you always have to keep that in mind. So these are some of the concerns that we have. And what they have said is that I don't know if that is true in India, because they have claimed, at least from what was presented, they have said that you don't need an ethics committee clearance for analyzing this kind of data. But in India, we do. Even if it is, you don't need a consent from the individual, you need an ethics clearance. You have to put it to the ethics committee and they have to say you don't have to get consent. So that is very definite in Indian situation. There is also a law. I mean, I'm just saying this because people should not get into trouble. So even if you are looking at retrospective published data, you have to get a clearance from your ethics committee. And I'm not interviewing the individual, so please let me go ahead, and they will say yes. So that is the procedure. Anyway, with all this, I don't think that this particular study, I mean, like what Dr. Padmanabhan said, if somebody says that this is finally cleared the confusion, I don't think so. I don't agree with that. I think you have to look at it in a more comprehensive fashion. As a study, as such, it's not a bad study. They have used a lot of data and looked at Mexico in a particular light and seen that with high levels of coverage, probably it works very well. And that is all I can say. Thank you.
Thank you very much, sir. Over to Dr. Padmanabhan, sir, for his comments as a mentor and the person who has chose the study from the first time.
Can you hear me now? Yeah.
Yes, sir.
See, the basic fact I want to send across to all pediatricians is who made the mistake of attending the national conference. Don't go away from the conference with the idea that now AP vaccines are as good as the WP vaccine. Because the main problem was the duration of action, which has never been addressed in this study. It is only up to 5 years. And up to 5 years, it was well known that this AP vaccine and WP vaccine were equally effective. The problem was when 18, 20 years, it started waning. And when it started waning, you found out that the adults started getting whooping cough, which was just a cough for more than 3 weeks. They never used to die or anything, but they will transmit it to the mothers and the mothers will transmit it to the children. And therefore, the neonatal mortality went up even in Western countries because in neonates, the normal childhood immunization does not protect because they start at 2 months, we start at 6 weeks. And neonate gets this because whooping cough, there's no transplacental immunity. But unlike what Dr. Amal said, the maternal immunization does protect. He said it doesn't protect, it does protect. But it is not done in India. Maybe in some private institutions it is done. So far, the government has not thought about it, giving TDAP for mothers. Therefore, that should be very clear to anybody that therefore, if anybody said this has put a lid on the main issue has not been addressed. Neither is this the emphasis that they gave in the conference was this is a real world study, follow up for 19 years. No other study has matched this study, but we have already said there's a lot of what you call limitations in the study. And when we assessed it by the strobe method, Dr.Gopika brought it out very well. And I'm happy about it. And let me tell you one thing here, which is very important, funding. See, when do you change your practice? Pediatricians, please listen to it. How do you change your practice from one vaccine? Now you have the government is giving wholesale vaccine is found to be very effective. Private, you were giving SLA vaccine because only SLA vaccine was available in hexavalent form. Now Serum Institute has brought about a wholesale vaccine which is available in hexavalent form. Therefore, each pediatrician should have to take the decision. When you take a decision, how will you do it? You first read about it. You ask your peers. Now we have the chance to attend to this journal club here, which is assessed by people like Dr. Ramankutty, who is the ultimate authority on it, and make a decision. Let me tell you, I will never, for MRCP exam, they make it very clear, don't change your practice by an article which is funded by the company itself. The Sanofi company manufactured the SLA vaccine, and they had done everything in that. I don't know what she put up the last slide, data collection. I don't know what the authors did at the end of the day. But anyway, therefore, definitely this is not a article by which you will change your practice. Then what will you do? You will wait for the same, this to be repeated in other subcontinents, in other populations, and probably by better methods, and then only you'll change your practice. That is my take on it. That's the message I wanted to convey by picking up this article. Thank you.
Thank you so much, sir. Now the forum is open for discussion. Oh, okay, fine. Sir, Ramankutty sir, Padmanabhan sir was telling about this Sanofi factor. So previous also we have discussed this factor regarding funding by the pharma company and all. So how exactly would you make sure that the article which comes out of the study is free of any, like skewing or some issues like the factors which can be affected by the funding by the same company and all. Can we make sure that, or should we think like this, that every article which has been funded by a pharma will be, it should be taken with a pinch of salt or something like that?
Yeah, what he said is absolutely right. You should have a high index of suspicion, and you should not be ready to change your practice based on something obviously largely funded by the pharma. for their own product. Of course, there may be some truth in that, so keep it in mind and look for other evidence, and please be patient. Don't jump into, oh, this is the last thing, and then change your practice based on that. So that would be highly, not the right thing to do. And now, of course, because all these specifications are there about conflict of interest, most of the good journals will publish this kind of stuff. And formerly, they never used to even reveal that they are behind the article. Now they had to. Otherwise, if they are caught, then it will create a huge ruckus. So they don't want to do that.
If this vaccine,
Sir, one more doubt. Sir, please,
this
sir. Padmanabhan,
vaccine
sir.
journal, a famous journal, is coming in vaccine. I don't know how famous it is.
Sir, one more data I have is that, sir, this data has been taken from something like a public portal. So we have many data in our country also, like in COVID data is there and all. So is it okay for any person to just go in and take visit the portal and take the
it is in
data
the
and
public
do some study
domain,
like that? Or do you need?
Yeah, there I think I made a mistake. But if it is in the public domain, you can actually. But if it is like in a hospital database, but it is retrospective, you still have to get a clearance. But it's like NFHS data, you can. But NFHS data, I think you have to apply to the NFHS and then get a permission to download it. I think that is the rule. So there are several such things, but some of the WHO and World Bank data are there for you to analyze. In fact, nowadays what is happening is that, for instance, the UK blood bank and all, there is a kind of a move towards public deposition. They put the data in the public domain, so with an anonymity, so that anybody can analyze. And there are such huge databases now available. And actually, that is a good opportunity. If you have good analytical skills, you can write papers based on those things.
Okay.
One thing I want to point out, because there are here, I hope you know that the definitions of vaccine effectiveness and versus vaccine efficacy. Vaccine efficacy is how effective how protective it is in those who are vaccinated. Whereas vaccine effectiveness is how effective it is in the population. Suppose you administer it to a huge population, then what proportion will be prevented. So that involves coverage also. That is the difference.
Sir, one more doubt I have, sir. Dr. Gopika has concluded regarding the equal effectiveness, something like that actually. But if we look at the exact numbers, it is 96.4 for Hospital.Pertussis and 95.7 for the Acellular.Pertussis and 97.3 and 97.24. I mean, a bit difference is there. So when we conclude a study by telling that it is equally effective and all, but doesn't these minor differences in the, effectiveness matter?
Significant, I suppose.
But if you look at the confidence intervals, I think they are overlapping, right? So which means they are not
fine.
Significantly different. Can't say they are different.
Sir, Padmanabhan sir, I have one doubt actually. In the definition, and in every textbooks, and we are being taught like that, at least 14 days of cough is needed. No, sir, is it like that? No, for diagnosing purposes like that. I mean, more than 5 days at least minimum, and 14 days is needed. So I was just wondering, when we diagnose this purposes, as in this case and that, do we really wait for this? No, we cannot do like that. So what is your comment on this? Do we just clinically diagnosis and?
See, it is like this. If one child has a whooping cough and you have diagnosed it, and it is, the whooping cough is one of the most communicable bacterial diseases known. It has got a lot of peculiarities, this whooping cough. It is more severe in girls. It is produce a lymphocytosis. It can be transmitted from mother to child, from birth to death. You can get it, etc. Now, if you have a child with whooping cough in your house, and if you have another child started to cough, that you can label it as whooping cough because it's epidemiologically linked. You understand? Therefore, you don't have to wait for 4 days.
Yeah,
and especially newborn, you should not wait. I still remember my shock. Shabari sir came, we took rounds in SAT hospital. I used to take rounds in the newborn. And there was a suspected case of newborn who had cough. And the mother had whooping cough. And I went and saw, and the gynecologist said, we want the Shabari sir to see the patient. Therefore, I was wondering why she acted. Shabari sir came back along with me and to the maternity ward, saw the child. And she said, definitely, this is a case of whooping cough. You have to diagnose as a whooping cough. And when he came out of the ward, he asked me, what did you tell the mother? I said, you have, probably it is whooping cough. That's all? She said, yes. She said, 100% mortality. That is the importance. You see, nowadays, with our neonatologists around who are doing fantastic job, I don't know. But those days, it was almost 100%. Mother is whooping cough, child is whooping cough, they're finished. That's the end of the story. And you must understand they will never have whoop. They will only have apnea. Therefore, that's why the term whooping cough is not correct.
Yes.
Paroxysmal cough is enough. And in newborn babies, there'll only be apnea. And if the mother has cough, then definitely.
Sir.
And the most, if you had looked at the data which was shown by Dr. Gopika in this bar diagram, you would have understood in all grade, major age group in which children had pertussis was below 6 months. It is more than 50%. Even after WP and ASL vaccine in the population, the reported confirmed cases were below 6 months was a major cause. And therefore that shows that even WP vaccine probably is not protecting completely.
Okay.
Maternal vaccine does, please remember that. But even in spite of this one, TDAP being available, 1,200 rupees or something, one dose be given for every pregnancy, maybe 22 weeks or 28 weeks, I suppose that's the time at which you give. Many of our gynecologists refuse to do it. I don't know why. Okay.
Sir, I have one more question, sir. Because doesn't this cellular pertussis vaccine have less side effects as far as single injection is concerned? So the parents may like decreased pain or something like that. And so is that factor actually favorable? Won't that factor come into play in giving this? So how should we counsel them, and what are things we should
see?
consider?
Let me, Anju, I'll answer that question. You have been working in health service for a very,
Yeah.
very long time, and you have been giving only
Yes, sir. Yes, sir.
vaccine. Now
Yeah,
you
for
just
the sake of the audience, sir, we have to
see, now when they come back to the second dose or third dose, I worked in PRS. When I joined in 2018, my colleagues were all giving SLA vaccine. I was insistent on giving wholesale vaccine. And when they came for the second dose, I will just ask them, how was it? They'll say, nothing, doctor. It's okay. He cried for a day. That's all. That crying was probably not acceptable to the Western world. Some of them even developed febrile seizures, and I continued giving wholesale vaccine. Therefore, there is definitely, but it is called mild side effects. Now, these mild side effects, for a mother, it might look, especially now the middle class having only one children, it might look too much, like hypotonic, hyporesponsive event is also considered as a mild event. But moderate anaphylaxis is the only contraindication. And when anaphylaxis or encephalitis occurs, then within both, it's a contraindication for both SL and wholesale vaccine. Now it is, you can discuss with the parent, because this SLR vaccine group promoted it as a painless injection. Nowadays, when they come to private hospital, in fact, the sister asks them, "Vedana ulla veno, vendatha veno?" Invariably, they will say, "Vedana illatha madi." And as I told you very clearly, the first dose, they say at least give wholesale vaccine, because a priming is very important. That's what has the herd effect as well as the long-term effect. But anyway, most of the private hospital SLR vaccine is promoted. The reason is very simple. There is a name for it, I forgot. The more costly the vaccine, more likely it will be popular, promoted at least.
So regarding the unusual question that which is addressed during such a session is regarding the choice of vaccine in progressive neurological disease.
Dr. Anju, and surprisingly, both the IAP textbook as well as even the Nelson's textbook does not deal with it in a very detailed manner. They give you a reference to the CDC site. You should go to the CDC site and see it. What is there nowadays? There are two things. One is anaphylaxis, other is precaution. Okay. Anaphylaxis means it is a contraindication for all time, because it is because of the person, not because of the vaccine. But when you have anaphylaxis, you don't give the vaccine for lifetime. Therefore, when you see a patient, I'll come to that later. Precautions are what all others happen. If you develop a febrile convulsion, among the anaphylaxis, other than among the contraindication, other than anaphylaxis, you have encephalitis. If a patient develops encephalopathy or encephalitis within 7 days of the vaccination, it is a contraindication for both AP and WP vaccine. Okay.
Sir.
Mind you, seizure by se is not a contraindication, but altered consciousness, which lasts more than 24 hours or something, then it becomes a contraindication for that. But now it is almost been proved that both the wholesale vaccine and SLA vaccine do not produce encephalitis, but CDC has not removed it from the list of contraindication. Now, all others are precaution. Now, coming to your specific question of neurological disorder, they say static disorders like cerebral palsy, absolutely no problem, you can give it. And global developmental delay, you are not maybe, it is not deteriorating, you can give. In progressive neurological disorders, still it is controlled. That's what we had in infantile, what you call as West syndrome. They say unless it has stabilized, and the word stabilized, what does it mean? If the patient's getting convulsions, you are not supposed to give either of the vaccine, wholesale or SLA vaccine. But generally, pediatrician would say, let's give SLA vaccine. That's what they do. But therefore, in progressive neurological disorders, nobody sticks out and gives the SLA vaccine, and it gives the wholesale vaccine unless it is stable, burnt out and stable.
Yes.
That's what it is.
Yes. Yes. Okay. Actually, the forum is open for further discussion. If anybody has anything to offer, any extra points or something like that, we are free to unmute yourself and talk. So we are thinking that is why yesterday and
Shija, please, doctor, in the comment box you find that Shija has written. There's a bar diagram shows a sudden surge in cases after the transition to AP vaccine in 2007, which continued from 2009 to 2019, clearly showing AP vaccine is inferior to WP vaccine. Pertussis is lethal below 6 months of age, and was there any change in mortality after the transition in 2007? Well, they have not discussed this at all here, but there has been an epidemic in 2012 all over Mexico. That could be the reason, and they have not commented on it. They have here and not and they have said that many reasons are there for why this is increased, because the people have become more aware of it. Reporting has gone up further, and the PCR testing has become more common. Therefore, these are the reasons. They might have been the reason why the bar diagram is showing a continuous increase. Or it could be a real failure of the AP vaccine. That is not discussed in this. But among the vaccinated group, the protection was very good. Therefore, that means it doesn't mean that the vaccination was not effective. Okay.
Thank you, sir, for answering the question. I think if there are no other questions and nothing else to right now to discuss, we can end the session for right now.
Thank you.
And with everybody's permission, I would like to thank Dr. Ramankutty sir, Dr. Padmanabhan sir, and the excellent presentation by Dr. Gopika, Dr. Amalraj. Thanks to both of you. And is Benno here, Dr. Benno?
Benno boy.
Okay. Okay. In that case, we will end the session right now.
Okay.
Sir,
thank you. Bye.
Thank you all. Have a